Good morning, everyone. Good morning. We have a tight morning this morning because for the first time, our surgery course immediately follows this meeting. So I want to, for a change, stay on schedule, which is not typical of me, by the way, but I will. First of all, again, welcome. This meeting used to be so small, we'd go around the room and introduce each other, but during the time that you're here, make sure you meet the other people, those of you applying for fellowships, those of you looking at the glaucoma positions. And we're just so happy to have this group growing as the subspecialty of pediatric and childhood glaucoma, those things that are anterior segment total mess-up or just the primary congenital glaucoma, we're addressing all of it as best we can. This is the 13th year we've had a CGRN breakfast, by the way. The first year was 2011. Is that right, Anthony? 2011. And it was at an ARVO in Fort Lauderdale. And it was at that meeting that we decided we needed to have a classification system so that we would all be calling the diagnosis the same. Our next goal is to get this on our ICD so that it will be put into the electronic medical records correctly, so it's not just glaucoma childhood, and I mean, which is a hodgepodge. Then you go in and you have to figure out, what the diagnosis is. But if we have had promises made, and I'm not going to hold my breath, but I think it's something APOS can help us with, and it's a bit of a political issue. Maybe when we're in Washington, D.C. for AGS, those of us going, we can address this a little bit. And it was at that meeting that we decided to do the classification system, and then when the consensus book came out, it was validated worldwide. And now it is, I'm proud to say, probably the single most important contribution this group has made. That and then the consensus book, which will be redone. So if somebody wants, we want new people, young people to start participating in the publications. We're meeting for a second edition on the surgery book and a second edition on the consensus. So please call myself or Anthony or Dr. Chang, and as we start to create that plan for the new version of what is CGRN. So just to mention though our tight schedule a little bit, we're followed by the didactic lecture for the surgery course. And surgery course will be this afternoon at 12:30, but the didactic lectures are at 8 a.m. We have a little lecture session in the middle there, which will not be the primary congenital glaucoma kind of things, but more of those complicated anterior segment dysgenesis and how do we approach those. And on Monday, with the help of Dr. Ray AAO, we're going to be covering when you do those complicated cases and things don't go the way you planned, what do we do with those? So most of everything after this meeting today will be our surgery, CGRN surgery. I have to say, Dr. Bittman, who is here, I think she's here, with her children. Where? Oh, here she is. She is the person behind the surgery courses, which, by the way, it's, our wet lab today, it's been, what, 10 years?
Yes, that's right.
Yes. Is it 11 years? Wow. So, very good. So that's moving along. And I think also in the next couple years, those of you who want us to start assuming some of these leadership roles, I'm going to be ready to hand over the baton, so to speak. Speaking of that, I mentioned last year we've had a transition CGRN, and the GL Foundation, which sponsors CGRN in part, is working closely with the Balkan Center, which I established in 2017 we open the door, and now Dr. Peter Chang is our director, and Elena is the director of the education. So any of the things that are going on there, we're beginning to work hand in glove. In this meeting today, I want to thank Yoli so much, Anthony so much, Elena, for helping to put this meeting on. And so we have, I'm checking to make sure I'm still on time, amazingly we are. Yeah, oh, yes, that is actually the future events. And UKPGS is one that occurs every January. It sounds like the worst time in the world to visit London, but actually I have come to love it. There are very few tourists there. I don't want to sound European, but it is nice not to have everything be overcrowded, and sometimes it's absolutely beautiful weather, or it's, I don't know, I'm somebody who lives in Minnesota for a lot of the year, so to me it's just fine. And it is a very worthwhile meeting. The other meeting I want to promote will be the meeting in Hawaii. Which one is this one, Anthony? Oh, yes. And we have one of the, Dr. Jamie Brand, I believe, is going to be a speaker at this one. No, not this one. The next one. Yes. So, oh, this one's virtual. They alternate virtual and in-person. So this is the virtual meeting. The in-person meeting Dr. Brandt will be at. And so as we keep trying to, CGRN as an international organization is trying to bring things together. The other support that we have done for CGRN is really supporting and behind the North American Pediatric Glaucoma Society, which is really off to a terrific start under the leadership of Jamie Brandt, Lauren, next to Jamie, they've really got this going. Daniel Vu is going to give us an update on that today. And so these are meetings too. Again, if you have a primary interest, and I assume you do if you're here this morning, in taking care of children with glaucoma, then these are the people you want to hang out with. So this is your community and your crowd. Okay, so our first presentation this morning is going to be by Dr. Daniel Vu, who is going to give us an update on NAPGS. Daniel?
So I'd like to give the update on the North American Pediatric Glaucoma Society membership platform. And so we're currently doing beta testing on the membership perks. This is our website, and I'll have a QR code at the end of this set of slides that you can sign up to give us your information, and then we'll send you a link to the application once it's ready. But first, this is our website that you can check out if you haven't yet. And I would like to go over the membership benefits and tell you why I think it would be, this would be a great benefit for you to join. The first benefit is that we have a forum that we're actively beta testing right now, so we password protected, and members will be able to ask questions to other members pertaining to their practice. And also we have a annual meeting. So this is what the forum will look like. This is an example of questions that you can ask. So this is an example of a question that's being asked to another forum member pertaining to disc hemorrhages in children. And we have a little search bar on the right where you'll be able to easily access other previous questions that have been asked. You can see which recent posts have been posted recently. So it should be a very user-friendly website that we hope will be a great benefit to members in the society. And other benefits include reduced annual meeting fees, access to our membership directory so you can ask questions, or let's say you have a patient who's traveling to a different part of the country and you want to get a hold of that member who's in that part of the country. You can try to coordinate care through there. By being a member, you can help participate in future multi-center collaborations that the society will be involved with, and you will have access to logos, templates, and guidelines that the society will be publishing in the future. So we hope that you join this society, and this is a QR code to send us your information, and then once the application for membership is ready, we will send you the link for the application. Is there anything that JD wants to add?
If you can all hear me, I would just say that one of the concepts of this society is to not avoid industry, but to engage industry in working with us to look at devices and drugs for the pediatric population and design clinical trials. Right now, there's a lack of expertise both at the FDA and in most industry on how to think about dealing with childhood glaucoma, and that's something we really want to catalyze as part of this meeting. So if you have relationships with companies that are developing devices or drugs that you think might have a particular niche in childhood glaucoma, this would be a meeting where they're going to be able to work with us, perhaps to develop a clinical trial or to get our expertise in how to design a clinical trial.
So we hope you scan this QR code, and if you miss it, I have it on my phone, so if you find me after this meeting, I can show you the QR code.
Thank you so much, Daniel. And now Dr. Chang is going to give us an update on the Harley CGRN registry.
So Alex cannot be here, but he sent me some updates. Since last year, we have acquired 3 additional centers. I'm proud to say Glaucoma is one of those. Now the Harley CGRN registry represents 14 countries and has over 1,000 patients enrolled. And the most excitingly, the first paper based on this registry has just been accepted for publication in City Press in Glaucoma. And it's kind of a landscape publication looking at different types of glaucoma management styles across different countries. And there are at least 2 more projects in the pipeline. Right now, the Harley is being used as a cross-sectional tool, but as it grows and as members start to input longitudinal data, it has the potential of being a very powerful longitudinal study tool as well. And Alex was kind enough to include the QR code as well. So if you're at the center and you have a sizable number of pediatric glaucoma patients, please consider joining the Harley registry. The buy-in is 10 entries, so if you contribute 10 patients, you will then get to submit a proposal to the board of directors at the Harley CGRN registry, and once they approve it, you can align the data to the registry for research. Thank you.
I want to mention that it's interesting that we're getting sort of a bird's eye view with this first paper from the Harley CGRN registry, because one of the first things we did as CGRN was something similar called IPSOC, which was an international pediatric glaucoma survey, which was just a snapshot in time. And the interesting thing is they match with this paper that is coming out, and I'm really excited about that. It sort of validates what we've done in the past. He's going to teach me. I cannot edit videos. Okay, and so this seemed like something very valuable also for CGRN, because listen, for those of you who have surgical videos, and I see some really terrific surgeons who have a lot of videos on their websites and everything. If you want to share them on the CGRN YouTube, it also creates a very good international. We give you credit for it. We watermark it and make sure that they're not going to be used. But how to make these videos, it seemed like something that we should learn. So Mohamed is going to give us this talk.
Well, thank you so much, Dr. Khodiery. Good morning, everyone. I'm Mohamed Khodiery. I'm one of the glaucoma specialists at University of Louisville in Kentucky. And the title of my talk today is Tips from a Millennial to make a modern surgical video. I have no financial disclosures. So why it's important to record our videos? First, to learn and self-audit, especially early on in our career. Second, to teach residents, younger surgeons, and if we have novel ideas or for publication purposes. Also to contribute to professional meetings and in rare occasions for medical legal purposes. So I like to think of videos as, surgical videos as movies. There's this pre-production phase where we're preparing, setting everything up, and then the production phase where we're shooting and the post-production stage, we're going through our footage, editing it before sharing with others. So good surgical videos should be clear with good composition, and should be of appropriate magnification, either while recording or editing. It's better if it's an appropriate magnification while recording, because with editing, if we try to zoom in or zoom out, the quality of the video can decrease. Also, videos should be focused and centered. Also, the field in the microscope is larger than the recording system. And here I'm showing a good example of a good surgical video. What not to do. This is a bad example of what not to do. Here, I'm pushing the eye out of focus, E-centered. I'm seeing actually the canthus, and the speculum more I'm seeing the eye itself. So keys to a good surgical video, we need to start with a good topic that's interesting to our audience. We can show complication and how to manage them. And even if we are presenting routine cases, doing an awesome show using 3D graphs, illustrations, or if an expert surgeon, like a lot of sitting in the room here, are sharing their special knowledge and providing tips and tricks while doing these surgeries. It's important to adjust the recording setting to the highest possible resolution, because with the lower resolution, we lose a lot of details of the picture and the videos. And it's important to be aware of the room and microscope lights, because if the OR lights are too high, sometimes we get this overexposed videos or a little bit of shadowing, which is very difficult to edit. So it's better if we can record in slightly dimmer light, and also we shouldn't increase the microscope illumination too much. You want video?
You start with 0 to
Yeah. Thank you. Also, we need to keep the camera rolling. We don't know when things will get interesting. Yeah, Argentinian flag. Yeah, we need to cut. We need to edit our videos because we as a surgeon will be more interested in watching our videos than the audience. And that's the truth. And also with this, we are in this era of TikTok videos, social media, and Instagram reels. Our attention span is getting much shorter than it was before. So like on average, a good video should be around like 5 to 6 minutes, and we should grab the attention of the audience in first, I'd say like maybe half a minute. We should focus on the main steps of the surgery. There's a lot of steps that we can skip. Pre-filling the eye with an OPD, doing a Khodiery for a minute. We should know our audience. If these videos are patient targeted versus if they are surgeon targeted. We shouldn't distract the viewers, so preferably no background music, and if we decided to use a music, we need to make sure that the volume is not very loud. Using simple transitions between different segments of the video is important. I usually use either solve or fade. If we're decided to add text, we should use simple short word slides. And if you narrate the videos, we need to make sure that we speak clearly. And in important steps of the surgery, we can try to direct the viewer's attention either using arrows or so. And at the end of our video, it will be great if we can add a satisfying conclusion, like discussing the outcome of our surgery, adding post-operative photos or take-home messages. We need to archive our videos, preferably in 2 separate places. It's not uncommon to happen that we lose a hard drive. Stop working. And name our videos in a way that can be easily retrieved. This is a screenshot from my fellowship video just finished last June. I used to name my videos in a funny way, but it's very easy to retrieve. So in terms of the editing software, there's a lot of software. Some of them are free, but these are the most commonly used software. So I see some are free, like the iMovies on Mac. It's free, very easy to use. The DaVinci Resolve is also another free software. It's free to use, but you can upgrade to a more sophisticated version called the Studio version. I have no financial interest, but it's around $300. Other paid softwares are Adobe Premiere Pro, which is the subscription is $260 per year. Final Cut Pro is a one-time payment, $350 Filmora, there's a free version, there's a watermark, and there's other plans. I think the basic one is $50. Other online platforms for editing are WeVideo, Majesto, and YouTube Editor. So I'm gonna show here in the next few minutes quickly the basic steps of how to do video editing. So here's I'm gonna use iMovies. So it's the interface. To the top right, we can see the media part, and down there's the timeline, and the preview is on the right top. So here I just added the video I want to edit, and just going quickly through it, scrubbing, and then dragging down to the timeline. And in our recording system, it always there's an audio attached to the video, so I'm trying to remove that audio, just background noise. So I right-clicked, and then I clicked on detach audio. Then I'm deleting the audio. Then I'm ready to start editing the video. Here come the actual editing part, just trying to split the video and then deleting the unnecessary parts and connecting them together. Okay, so here, like traction switcher, lifetime, so I want to delete this part. So I started on the part that I want to edit. I clicked on Command B to split at the beginning of this segment. Then at the end of it, another Command B. And then I highlighted this part and click delete, so it's deleted. Doing the same with the periotomy part. Click on Command B, and at the end, another Command B. And then deleting this part. Now after, like, at the beginning of the video, I have 3 separate segments. But when you try to play the video, the transition between these parts are upward. So I'm gonna add transitions to make it more visually appealing. So I clicked on transition, double click, I choose to solve, I wanted like a smooth transition. So if you go back to the video, we can see that the transition now is much better. And another feature, if we want to select a part of the video but not split it or delete it, just from the keyboard, I just click on I for in, and then O for out. Then I have this part of the video selected without splitting it. If there's a search step that I want to show, but like in a faster or slower speed, do the same. I start selecting the part I want to edit, clicking on Command B at the beginning, then Command B at the end of the part that I want to select. And so a lot of this section. You go to the right top part of the screen where the speedometer sign is, and change the speeds from normal to fast, like a preset speeds like 2x, 8x, 4x. And then if I want to show it on a slower speed, I change it to slow and choose which the percentage of how much I want the video to be slower. You can also add freeze frames or still photos to this part of the video. And if I want to add a certain speed that's not in these presets, like for example, I want this video to be 1.5x speed, so I can change this percentage from custom, I can change it to 150%. Then if we're doing a certain step and we want to show it in higher magnification or zoom in, so if for example we're trying to identify the Schneid's canal, so you click on crop and crop effect, I choose this part, centered it on the area of interest, then click enter. Then now if we go back, it's more magnified and more obvious. After you're done with editing the video itself, I want to add some title slides. So go to the background, I choose the symbol black background, then choose the text I want to add, and then write on the video title. So that's enough. Same thing if I want to start adding a text to the actual video, I go to the certain step that I want to add text to the video. Here, I choose the text. And it's now added to this part of the video. If I go back, I can see it. And if I want this text to last longer, I can just drag it. Now it lasts longer. In terms of video narration, it's very simple. Just from the microphone icon, just click on it, and then start recording. And then, as we said, you need to speak clearly if you are audio narrating your videos. After we're done, just click stop, and the audio part get added to the timeline automatically. We can control the volume by moving this bar up and down. And if we want to add background music or an audio to the background, just drag it to the timeline. And as we said, also we can control the volume. After we're done exporting our video, there are two ways of doing it. We can either go to the file, then share as a file, and then choose, we can change the quality of the video or the resolution, and then rename the video if we need to do. Another way of doing it is from the share icon on the right top part. So these were the basic steps of video editing, and this is what I have for today.
I think, Elena, this should be added to our surgery book. If you're interested, we're meeting with Springer actually at this meeting. So now I'd like to introduce Sylvia and the review of publications from this last year. I hope it's as exciting as we did before. I'm not sure.
I sure hope it is too.
Very good.
We'll see if I get invited back for year 3. That would be the deciding
I would be
factor.
honored.
Yeah. All right, Anthony. My slide. So I did go through again and really tried to focus on the papers that have been published within this last year. I didn't obviously have an opportunity to share everything that I would have liked to share. There's a lot of dramatically increasing number of publications on pediatric glaucoma, which is awesome. I'd love to see that. So keep doing, keep learning, keep publishing, because I want this challenge every year to figure out what papers are interesting for us to share and to take a look at. I'm just gonna do a bit of a flyby. I'm not gonna get into detailed depth, but a couple main takeaways of what the authors looked at, what my takeaway was from it, and kind of, if nothing else, point you in a direction to read further and to look more into if there is a particular interest. I'm happy to discuss after the meeting this morning of any details that I found. So no financial disclosures. I picked out 5 different categories of papers that seemed like an interesting thing. A couple surgical, a couple outcomes, and then some findings pieces. So targeted at the diverse audience that we have here. Some more experienced in pediatric glaucoma and some less. So let's just jump right in. So I'm guessing many of us in the room did see and read this paper that came out. A very impressive duration of follow-up of surgery for primary congenital glaucoma that happened in the 90s into the 2000s. There were 220 eyes at LD Prasad that were looked at. Most of the focus here is on the TRAB, which is the trabeculotomy, trabeculectomy, and that was done without mitomycin C. But in this group, about 20% of the numbers were made up with patients with a traditional trabeculectomy with mitomycin C, and 16%, and 4% had a cyclophotocoagulation. Most of the patients had severe primary congenital glaucoma. About a quarter were moderate and a few were mild. The primary outcome in this paper was complete success. In glaucoma terminology, when we say complete success, we're indicating success without medications on follow-up, and typically a qualified success has to do with a patient having surgery plus medications after. And the success category in general is pressures between 5 and 21 in that category. So it's a fairly consistent, but always exceptions for each paper is a little bit different. These are the Kaplan-Meier curves, kind of the main takeaway of the survival of both the trab as well as that 20% of having a trabeculectomy. They subdivided these patients into the 3 categories of primary congenital glaucoma. Those are the 3 lines in this graph. And this goes out to a tremendous 30 years on this graph. I made a vertical line at 20 years, because you can see down below the number of patients at risk. At that point, after 20 years, does drop off fairly significantly, but I feel like there's just a very robust number of patients up through that 20-year mark, which is incredible to have follow-up over that period of time with that number of patients. And you can see on the left, we have the complete success, so not on medications. At 20 years, right around 50% of the patients were considered complete success, and a far higher number on the graph on the right side, which is the complete plus qualified success, which indicates that the number of patients that were still on medications. And so that was a really impressive follow-up. So overall, the IOP was well controlled over 20 years. Visual outcomes was a big piece that they collected. About a third of the patients had good vision, which is categories 20/40 or better. 16% in between 20/40 and 2200, and about half the patients were worse than 2200. And that was for the various reasons that we see in primary congenital glaucoma for limiting vision. The intraocular pressure graphs over on the right here. Notice that the y-axis does start at 12, and so just for reference, the graphs always look a little bit different if you start at 0 versus closer to the target point. It can be useful for graph demonstration in certain cases, but as a reader, being aware that can skew your perception of the data. So it's not right or wrong, just be an awareness piece as we're reading. I did appreciate the comments at the end of the case, and it just bring us back to the fact that anesthesia risk is real. Keep in mind, these surgeries were done between 1991 and 2000, so this was literally a generation ago now. And so the advancements have happened, but it is always a risk when we do put children under anesthesia. And so unfortunately, a couple of the babies did not survive the surgery and had challenging recovery. So I'm thrilled with the amount of innovation that we've had in overall healthcare, but something to keep in mind. Then move on.
Can I just interrupt? I
please
thought
do.
you were quite nice. You did a great job.
Yeah.
This is Anil Mandel, the first author.
I am so thank you for the contribution. And I did the summary justice. Glad I didn't know that before. Perfect timing. So I don't think Sir Penpa is in the audience. Please stand up. So this is a very large cohort that has to do with very rare pediatric uveitic glaucoma. These are some of the, there's a lot of categories of the worst of the worst in pediatric glaucoma, but this is one of those categories of the worst of the worst. And they did a really nice job looking at the glaucoma drainage device outcomes in this group. I know we've had a couple good papers on this topic, and this is looking at 50 eyes in 36 kids, 5 to 17, meaning a follow-up of about 9 years. These patients all had tube shunts placed. They went into the eyes when they were quiet. They didn't give a defined duration of quiet status, but they did not go into active eyes, and they looked again at primary outcome of the rate of success. So I think one interesting piece is that these, as they do in the Moorfields Hospital, they use mitomycin C. 75% of the patients were augmented by a dose of around 0.4 mg per ml. That still is not the standard surgical procedure in the United States, but I know that it is. We do it from time to time. But this cohort did include that for 75% of the patients. About 20% of the patients lost more than 2 lines of acuity. But as you can see, the outcomes here at 10 years, still 23 of the patients were at risk, and these were including the folks that had already failed. So they had a tremendous follow-up of this cohort of following them over time, perhaps with the chronic disease and then following up medically. They're able to keep the eye exams. But their survival percent after 10 years was close to 70%. So these are phenomenal surgeons using the mitomycin, having some good outcomes in a very difficult disease. They definitely needed to do reoperations. A second glaucoma device was needed about 20% of patients. Cataract surgery, of course, in this cohort, if they hadn't already needed it, was done in a lot of patients. I paid a lot of attention to the tube exposure, which is repeatedly talked about as the concern for some folks to add mitomycin to tube shunt devices. There was a surgery for tube exposure in 3 of the patients, and then a plate was removed due to exposure. 1 DSEC, always, again, a concern of having the tube in the anterior chamber, especially from a young age, of causing corneal complications. The hypotony was similar rate. So overall, my takeaway is that refractory uveitic glaucoma really can successfully be treated with glaucoma drainage device. And I think that's oftentimes one of our main and only options to go to. But it is helpful to have this series to help counsel parents on what to expect and what our numbers are. Keep in mind, if you do not do the same technique, it may not be directly applicable. So we go into a third procedure in a group of patients. I really liked, I will say there's a lot of great CPC data out there. Ray, I know you had a chance to share with us some of your CPC stuff at that meeting earlier this year, which I appreciated. This is the one cyclophotocoagulation study I chose to highlight. 262 eyes were included, and over a relatively long-term follow-up. I say relatively because our previous ones were 10 and 20 years, which is extraordinary, and this is an average about 5-year follow-up for these kids. They looked at, the average age was 5 years old. I had the settings that they used here, and this was the continuous wave cyclophotocoagulation in this study, titrating to POPs, 1500 milliwatts, 1500 milliseconds. This is, I thought, was interesting in striating the outcomes of the CPC based on age of over 5 years or under 5 years. And so you'll see on the blue line are kids that were older than 5 years that had a higher success rate than the children that were under 5 years in the red dotted line. And that was a main takeaway from the authors, that older children really did show to have a better outcome. On the left side is when only 1 CPC was allowed. On the right graph, it was when a repeat CPC was allowed to still be counted and qualified for success. About 46% success rate in that case in the right graph. They broke down the responses for these patients, and about 40% had sustained IOP lowering with a single treatment, which was great. And sustained they defined as over a year. But you'll see the other categories, 20% had needed multiple treatments, but 25% had no effect. And that can be discouraging as this procedure is often gone to when we really don't have other good options anyway. So, you know, bringing that in with your expectations, that there may be children, especially the ones under 5, that really won't get much of an effect. They define no effect as no control at the 6-month mark.
So the question, what
Yeah,
was
please.
the definition of success for that study?
So for this study, the definition of success was pressure under 21 after 3 months without the need for additional glaucoma surgery or repeat CBC. Yeah, and so some fell out for the surgery reasons. Good question. So these last two, a little bit shorter studies I'm going to briefly touch on. I thought that this was interesting. This is just a little study that I think we have clinically, a lot of folks have that question. How many children with large clear corneas do not have glaucoma? This is what we're getting sent, this is what we're seeing, and what should be our kind of pretest probability as someone's coming in, perhaps. One must read the study carefully to see the inclusion criteria of who they are seeing. This is not a population study. These are patients that were sent to the hospital in Alexandria over a 10-year period of time for large clear corneas. Some of these children did have findings on the opposite eye, so they had a reason to be sent in. So this is not just a incidental measurement of large corneas. I know from our peds colleagues, a lot of kids do come in just with large eyes all the time. And so this is a little bit more of a selected group. They were looking at patients with white to white over 12 millimeters. Diagnosis was based on the CGRN, our criteria. And they looked at axial length to filter out those with congenital high myopia. And so in the, they ended up looking at 120 eyes of 91 patients, more male than female. On this, they thought had perhaps an impact. So of those, 67 were glaucoma, 17 had axial myopia, and 7 were defined just as megalocornea. Of course, the intraocular pressure was a very important piece of the exam to help delineate what could be present. Hobsturia were found in 15 eyes, which were not seen initially on exam or for referral. And you can see the axial length that glaucoma does have the largest axial length at 24.5 millimeters, but the axial myopia was nearly 24 millimeters itself. So this kind of shows roughly, most of these patients do have glaucoma, but about 20% probably don't, and it is okay to define patients without glaucoma and just having the incidental large eyes. Some of these were presumed to be spontaneously arrested glaucoma, and that may have been the reason for the large cornea. So a glaucomatous process, but nothing that was needed to move forward and treat. Okay. This last case series that I put up here out of MCW just caught my interest, and I wanted it to be on people's radar in case this is something that's going to be seen more. These were open-angle glaucoma patients. This is 3 cases, very small series, so take it with what the weight that it deserves at this time. All of these were severely premature babies, 23 to 24 weekers. They developed stage 3 ROP, were injected with Avastin, and developed open-angle glaucoma about 4 weeks after the injection. And so on these on these kids, they really felt like it was related in the time course of the Avastin injection. They know the anatomy is so poorly developed at extremely early ages. But I hadn't heard about that. We know that glaucoma happens in a lot of ROP kids for a lot of reasons. Most of those are on a bit of a delayed presentation. A lot of them are stage 4, stage 5 glaucoma. A lot of them are delayed presentation or after complications from scarring, neovascularization, closed angle, certainly some open angle. So all those exist. This just sounded like a different pattern than what I had typically seen and what I was familiar with. So just put it out there as we're watching these really young children and glaucoma. It's just an interesting case. And that brings me to my conclusion. And I have an increased graph in the number of papers that are being published every year, which again is very exciting. Keep working, keep innovating, and keep making it harder to decide what are the interesting papers to present.
Thank you.
Thank you.